Good day, everyone. My name is Matti Tolonen. I'm a consultant emergency surgeon from Helsinki, Finland. And I'm very honored and humbled to give the BJS lecture of the ASGBI 2024. And I'd like to thank the BJS and the ASGBI for the honor. So I was asked to talk about the emergency general surgery, the EGS model in Helsinki. And another part of the talk will be about our pathway on acute mesenteric ischemia. And I'd like to stress out that I'm not trying to tell you that our system is the best. It's just I'll tell you how it's like. And I have nothing to disclose. So just very briefly about Finland, we are down there in the south, in the HUS corner. There are not many people in Finland. It's a medium-sized country, but most people have centrifugated down to the south. And from the waist up, there's not so many people. There are more reindeer than people. Our hospital the system is quite centralized. According to some calculations, we are the third biggest hospital in Europe. And all the hospitals under the Helsinki University Hospital umbrella have about 2,600 beds and 27,000 employees. The general surgery happens mostly in these two hospitals, which are about 10 kilometers apart in the capital region. I work in the Meilahti Hospital campus, which is in Helsinki, and Jorvi Hospital it's actually even bigger in terms of operations and patients than Meilahti. So the division is that in Meilahti hospital area, we both have emergency department and a dedicated emergency general surgery system. The elective surgery in Meilahti has a tendency towards being more heavy duty compared to Jorvi, which takes care of a lot of laparoscopic, robotic, daycare surgery, etc. But they also do abdominal wall restruction and colon cancer surgery. In our hospital, we have all surgical specialties in house, pretty much in all hours. And in Jorvi, the operations are mostly general surgery. There is no talking about emergency general surgery in Finland without mentioning Professor Ari Leppäniemi. So he's the grand old man of the whole thing, and I had the huge privilege of having him as my mentor for a decade and a good friend nowadays also. So when he came back from at 1996 from the US, he started to manage EGS patients part-timely, and he climbed the ladder, and at 2003 he was the chief of emergency surgery and surgical intensive care. He has had active research programs for most aspects of EGS and trauma. He has a very extensive international career, and with his reputation, we have had the privilege to have dozens of international visiting surgeons at our hospital. In UK and Europe, there's a gradual development going on of dedicated EGS models, and in the US, in comparison, there's the acute care surgery model, which is a little different. So this is the timeline. Back in 1995, everything was done between elective surgeries with the left hand, with no special emphasis on EGS. So gradually, first there was Ari as a dedicated EGS surgeon, and now there's 4 of us and 1 fellow at the same time. We have dedicated emergency operating theaters, started from 0, and now we're up to 3 or 4 in our hospital, which is the Tower Hospital, and now it's been joined with the Bridge Hospital, which is interconnected, brand new hospital, and it has another 4 ORs for mostly bone trauma and neurosurgery. We have nowadays 2 floors in our hospital altogether with 60 beds for EGS patients. And the high dependency units have been on and off. Now we have a shared HDU with other specialties, and there's an big ICU which is shared with other specialties as well, and it's been run by intensivists, and we usually have 3 to 8 patients there each day. Another development with the EGS model is that the surgeons started to do ICU rounds daily back in 1996, and we still do those. We have a handover system twice a day nowadays. There's a traffic light system for the emergency surgery coding. I'll show you next slide about that. And let's move on. So this is something that Ari developed together with his colleagues a while ago, but now the model has been made a bit better, and now it's been used in all of Finland. So it's the national urgency coding for the urgency of the emergency surgeries. So with this coding system, it's far easier to make decisions on who should go to the OR next. At our emergency department, we have more than 100,000 annual visits. There's 5 CT scanners in the ED area. We have about 800 trauma team activations annually, and our catchment area for tertiary cases is around 2 million, and for normal diseases, we also manage the people of Helsinki, which is about 600,000. We do, in these 2 interconnected hospitals in Meilahti campus, we do more than 10,000 emergency surgeries a year. About 2,500 are abdominal emergency surgeries. We have altogether 38 operating theaters. All of them we can't keep open now due to shortage of staff, but we hope that will get better soon. We have 4 hybrid theaters and endovascular surgeon. There's a vascular endovascular surgeon and an interventional radiologist available in 30 minutes in all hours, which really helps with, for example, acute mesenteric ischemia. And also we have this brand new fancy Raptor suite where you can do in the same bed without transferring the patient. You can do CT scan, angio, and open surgery. It's kind of fancy, but very demanding staff-wise. So the second part of my talk will be about acute mesenteric ischemia pathway, and I'll tell you a short story of why we had this development and how it happened, and what did it do to our results. So first, we'll be talking about acute arterial occlusive mesenteric ischemia, and the pathway is only for that, not non-occlusive versions or mesenteric venous thrombosis. So here are the classic CT images, where you can see on the left side, you can see an SMA embolus, and on the right side, you can see a thrombus at the root of the SMA. And here is some dusky bowel and a classic open embolectomy via laparotomy. But just a friendly reminder that all bowel ischemia is not mesenteric ischemia. This was a very sad case of a patient. Once we started talking a lot about that all these patients should be centralized, so in another hospital they saw some non-enhancing bowel, and the patient traveled around the capital region, ended up having a perfectly nice SMA open and a very simple strangulation, which could have been managed in any hospital with operating room capability, and the patient ended up dying because of the delay. And also to remind you that left-sided colonic ischemia is there's no revascularization of the IMA. being done anywhere, to my knowledge. And if it dies, it needs to come out, and there's no need for vascular surgery in these patients. But on the right side, we can see that the very distal end of the SMA gives the blood flow to the right colon, and that can be involved in acute mesenteric ischemia. So this is a disease with a terrible reputation, because in most centers until the late 1990s, the management was only to resect the necrotic bowel, which resulted in about 80% mortality and a terrible reputation for the disease. We can see that the incidence in all patients is not very high, but when the patients get older, the incidence tenfolds. From this chart from Jussi Kärkänen's PhD thesis from Eastern Finland, we can actually see that the black line is acute mesenteric ischemia, and the green line is acute appendicitis. We can see that at the age of 75, the AMI is more common than acute appendicitis, and gets increasingly common with increasing age. We can also see that compared to ruptured AAA, AMI is more common at all ages. So the prognosis, the published prognosis, depends very highly on the cohort. If you look at epidemiological studies versus endovascularly managed patients, it's obviously very different mortality. Usually, the acute phase mortality is between 50 and 80% in unselected patient groups, and we can see that not all of these patients are even diagnosed alive. So there are lots of misdiagnoses. But those who survive the acute phase, get revascularized, get to go home, we still have 84% of these elderly patients alive after 1 year, and more than half after 5 years. So it's not futile. So we have a modern hospital with all the equipment, lots of skills and knowledge. So why do we need a pathway to manage these patients? Even though we had all the capabilities, we still saw a lot of far too long delays. There were problems with diagnostics, problems with decision making, problems with management, and so we decided to do something about this. The first thing we need to acknowledge is that this is compared to ruptured AAAs, ST elevation, myocardial infarction, massive ischemic stroke, or major penetrating trauma. This disease has higher mortality than any of these. And we have very well set up protocols and systems for all the other diagnoses, but we didn't have for AMI. So everybody needs to know that AMI is a surgical emergency that needs to be dealt with straight away. So we gathered up a group of experts on all the related fields to the AMI. We set up a few meetings, looked through the literature in a critical way, and modified the pre-existing pathways to our own hospital. And we did the pathway, which consists of 2 different pages. I'll show those to you very shortly. But in just writing a paper won't do much, so we had to give a lot of lectures, talks about it in hospital, regionally, nationally, and we were happy to have our protocol in place in the Finnish handbook of emergency surgery, which really helped distributing the knowledge. So this is the first page of the protocol, and we'll look at the different parts of it. At the emergency room, there needs to be a high index of suspicion for AMI, and the doctors on call need to be aware of the disease. If there's a suspicion, you initiate resuscitation, and you write the suspicion in a radiology referral, which is coded as a P1, which means immediate imaging. When the next CT scanner is ready, the patient gets to go there, and usually it's very, very fast. And consult early, more senior people. The role of the general surgeon is to be in charge of patient management and coordinate the management flow at all stages. And the decision needs to be made whether the patient needs to laparotomy or can it be done only by endovascular access. And at the laparotomy, the bowel resections should be done only to clearly irreversibly ischemic transmural ischemic bowel, and preferably after revascularization. And damage control techniques can be used, but they are not mandatory. And if the second look laparotomy is needed, the abdomen will be left open with a negative pressure device. And we need to follow up our patients very closely, especially if at the initial phase no laparotomy was done. The role of the vascular surgeon is to be in charge of the revascularization process. Exact diagnosis needs to be confirmed, and decisions where, how, by whom the revasc will be done needs to be decided. The results of the revasc process needs to be controlled either by flow measurement or control angiogram, and the vascular surgeon takes care of the postoperative medications on anticoagulative and thrombotic medics. And I cannot stress enough how important this is. It doesn't matter how good or how bad the patient is. All the delays should be minimized at all phases, since this is a disease that cannot really tolerate delays. So here is pretty much the same thing shown as a flow chart. And all of you interested, this all has been published and it's available for anyone. So this is the publication from the Journal of Trauma and Acute Care Surgery. And with the interest of time, I will not go through the details of the study, but I'll show you just the end result. So basically, we noticed that we had a problem. We decided to do something about it, and we were able to increase regional awareness, get more of these AMI patients referred to our center, which is the only center with vascular surgeons in the region. We got better with diagnostics. Our delays got a lot shorter. The revascularization was much more active, and as a result, the mortality went from 51 to 25%. I just wanted to show you this technique called retrograde open mesenteric stenting, which after the publication has become much more popular in dealing with thrombosis-associated AMI, and you can quite conveniently put in a stent to the root of the SMA during laparotomy from the distal parts of the SMA. So about the future, I am very, very much convinced that AMI has a massive potential for quality improvement worldwide, and I'm very happy that I've seen a lot of QI projects worldwide that has been started, and also the ideas or the protocol that we created has been adopted into various guidelines. And I do think that it's very important to do molecular studies, etc., and get to the very root of the diseases. But I think more importantly now, we really need to have our hospitals and staff prepared for these patients, and we need to get the patients early to the right hospitals in order to save lives. So my message, back to work, not back to home, but back to work, is that AMI might be the disease with most room for improvement worldwide. It's not a rare disease in the elderly population, We need to have a high index of suspicion. Regional awareness and fine-tuning local protocols will have an effect on the patient flow, and the patients need to be referred immediately to the right centers. An active revasc process is of paramount importance. Not all these patients need a laparotomy. In fact, in our study, only 50% of the patients actually needed bowel resection. And keep in mind that all bowel ischemia is not mesenteric ischemia, and these outcomes can be improved. Thank you so much for your attention, and feel free to reach out to my email. Thank you so much.